So I am honored to have the opportunity to talk to you about this topic today. These are my disclosures. So one of the interesting things about seeing patients with psoriasis is, in fact, exactly what you just asked about. We can treat psoriasis pretty effectively. So this patient comes in with some scalp psoriasis. Let's say he has a body surface area of 10% of his body covered, and it's really bothering him. We can give him a biologic therapy and get him substantially better. So we know that our therapies work for this. Our therapies don't work as well in psoriatic arthritis, as Frank just said. So this is a perfect lead into this. So one question this brings up is, if we treat someone's psoriasis, can we prevent or delay the onset of their PSA? So this was a schematic that we came up with a few years ago to kind of illustrate the concept that we think that many people begin with psoriasis alone, and then they have some other risk factors for development of inflammatory arthritis. And then something happens along the way that stimulates the inflammation, whether that's a second hit like trauma, some comorbidity like obesity, as was mentioned earlier, mechanical stress of the Achilles enthesitis, for example, causes inflammation. So when that inflammation is started, then you're off to the races, and there's not really a way to fully prevent anything from happening from there. But if we can treat the psoriasis, can we then prevent development of these downstream effects of inflammation in the joint? So in order to address that question, there's a lot of conceptual and design related issues that have to be considered and then dealt with. So first, you can't just right out of the gate do a trial. So a lot of observational studies have been conducted, and I'm going to talk through those briefly. And then some interventional studies are in progress now in randomized controlled trials. So when we talk about observational studies, one of the questions that we have to deal with is, why do patients get the therapy that they're on? If you simply wanted to compare patients who had received a biologic therapy to those who had received no therapy at all, there are quite a lot of differences in those patients. For example, patients who are on a biologic therapy much more likely have more severe psoriasis. They may also have fewer comorbidities, for example. They may be more bothered by the psoriasis and may be more connected with the healthcare setting, such that you may see psoriatic arthritis in those patients more often because they're better connected. So there's all these things to think about, and many of these things are not measured. We don't measure patient intent on getting a biologic therapy or patient's interest in getting treatment for their psoriasis, or how connected someone is to the healthcare system in general. So to address these questions, we can't measure those things and then adjust for them in models. We have to think about all the other things going on and think about how we might be able to identify proxies for those features. So there have now been a number of studies, I think 6 to date, that have compared the use of biologic therapy to either an oral therapy or to no therapy or phototherapy in patients with psoriasis, and the risk for developing psoriatic arthritis over time. These 3 were published around the same time. There's Paolo Gisandi published a study examining biologic therapies versus phototherapy. And in that study, he found, and his team found, that patients who were on a biologic therapy were less likely to develop psoriatic arthritis over the course of several years. And that was statistically significant at this p-value. You can see those curves don't separate for a very long time. So they don't separate till after 3 to 4 years. In addition, Maria Laura conducted a study with Enrique Soriano's group in Argentina, and they found something very similar. They used a different set of methods, including propensity score matching and adjustment, in order to identify which patients with psoriasis on a biologic therapy compared to an oral therapy went on to develop PSA. And they again found that biologic therapies in the blue were more likely to survive without psoriatic arthritis, so less likely to develop psoriatic arthritis over time. Again, if you look at the number of years here, these don't separate for a very, very long period of time, up until the 4 to 6 year period, and then they separate out here. Another interesting feature of this particular study is that it, and I'm sorry, I'm pointing to the wrong one. This is the graph for the Soriano one figure, but in any case, same findings. So they found pretty substantial hazard ratios, but when they did a different adjustment, so they changed the way that they were analyzing the data, the hazard ratio actually flipped. So it was no longer statistically significant, nor was it even protective, nor were biologics protective. It seemed like biologics in the alternative analysis were associated with more PSA. So that leaves a big question. And then this is the Israeli study that found, as I said, little separation, but there was a statistical difference over that many years. So we also performed a study, as well as Joe Marola, in 2 different administrative data sets within the United States. And in these studies, the opposite effect was found. So in both effects within the United States, it was identified that patients who were on biologic therapies seemed to be more likely to develop PSA than patients not on a biologic therapy. It's totally counterintuitive. So why would that be? I'm going to step you through a couple slides to kind of talk about this. But this brings up one of the very significant difficulties in using observational data, and that it may be different by region because of some of the confounders and some of the ways that the data is collected. So this is just showing that patients with biologic therapies compared to no biologic therapies had a substantially increased risk in this particular study of developing PSA. And likewise, if you added phototherapy in there, patients on biologics were more likely in phototherapy or oral therapy to develop PSA. And when you separate it out by therapy, it looked like certain therapies, like interleukin 23, this is the blue one here, maybe had better, lower risk for developing PSA compared to the other biologic therapies. So why would this be? Oh, sorry, before I go on to why, one other recent study, this is the most recent one published in Lancet Rheumatology, examined whether there was a difference among different therapies. So they didn't compare to no therapy or phototherapy or oral therapies. They compared to among just biologic therapies. And in this study, they found that use of a TNF inhibitor was associated with more PSA diagnoses than someone on an interleukin 23 inhibitor or IL-12/23 inhibitor. And then IL-17 was kind of right in the middle there. And Hosanna Scher and I wrote an editorial about this and why some of these why there might be some bias there. And Joe Marola and I also wrote an editorial on these observational studies and why we need to have trials to address these questions. Well, one of the reasons in the United States is billing. So when people code in the US, they code because they're going to bill something or because it's important to have that. So when we looked at who was coding among patients who were developing PSA and had developed it over the course of the next 6 years, what kinds of codes were happening? Red codes are musculoskeletal codes. So patients all along this time period are generally getting codes for musculoskeletal illnesses or joint pain. The one exception is in dermatology in the US. They didn't record any musculoskeletal codes at all. So it's kind of interesting that depending on what providers you were seeing, you were more or less likely to have these symptoms recognized. And it may not be that there was an issue with recognition. For example, the dermatologist may have recognized it, but they didn't code it because they don't get billed for that. They get billed for just putting in the code for psoriasis or rash and kind of moving through. So this shows the bias in how people put data into a medical record. And finally, in terms of one of the reasons that there may be bias in some of these observational studies is that when someone selects a therapy, they may or may not code for that psoriatic arthritis. So in general, the dermatologist is selecting the therapy, they're seeing the patient for psoriasis, they're coding for psoriasis, and then they give them a therapy. So if you have psoriatic arthritis, the dermatologist or rheumatologist is much more likely to choose a TNF inhibitor or an IL-17 inhibitor. And it turns out that this makes sense in some of the data that we see, in that if you got a biologic therapy or an oral therapy from a dermatologist or a primary care physician for psoriasis, within about 6 months, you get a psoriatic arthritis diagnosis in many cases. And that's probably because you finally saw the rheumatologist, and so they confirmed the diagnosis and put the code in. So this just illustrates many issues with using observational data to address these questions, and it helps us understand why you see studies going in both directions. So the first trial to address this question is ongoing. And so this is an interventional study in which patients who have risk factors for PSA, which I don't have time to go into it right now, including musculoskeletal ultrasound evidence of inflammation, but no symptoms or clinically overt signs of psoriatic arthritis, are randomized to guselkumab or placebo for 6 months. And then there's an intermediate time point where there's a power Doppler ultrasound. If patients don't want to be randomized, they can be just treated with standard care and followed over time. And then the patients in these 2 arms are treated with guselkumab and followed over time and will be compared to the observational or standard care arm at 2 years. So this is not going to address all of the questions that need to be addressed, but it's a first start in understanding how to conduct such a trial for prevention. So lots more on the way. There's the bottom line here is that there's insufficient data to say right now that treating with biologic therapy prevents PSA, but we're on our way to getting some more of those answers. So I will stop there and open for questions.
Thank you so much.
I don't know how to stop. There, stop sharing. Okay, perfect.
And is there any burning questions for Alexia, or should we go to the questions? There's a lot of questions in the Q&A. I think we'll start with this then. And one of the questions is there any benefits of detection early enthesitis by ultrasound and delaying or halting the arthritis?
That's a great question. So in the study, we are looking, in the PAMPA study, we are looking at ultrasound evidence for enthesitis and synovitis. One of the issues, though, is that ultrasound is a highly variable, it's very user dependent. And in particular, enthesitis is very difficult because you can, certain features of tendonitis, just plain old Achilles tendonitis, for example, look like Achilles enthesitis that would be a psoriatic arthritis or spinal arthritis related. So it's difficult to say right now, and I think we need more evidence around that first.